Hello everyone, this is Talk Elbaz, and today on behalf of all co-authors I will be presenting our abstract entitled Assessment of For the Flow Pulmonary Artery Energy Loss and Kinetic Energy in Pre-capillary versus Post-capillary Pulmonary Hypertension. Pulmonary hypertension is a predominantly a right heart disease that is life-threatening with various complex etiologies. Pulmonary hypertension is mainly characterized by elevated arterial pressure above 25 mm mercury and can eventually lead to right heart failure and death. Globally, pulmonary hypertension can be classified into two groups as post-capillary or pre-capillary, where the post-capillary patients are those with underlying left heart disease, whereas the pre-capillary patients are those predominantly with right heart disease or lung disease. Classifying the pulmonary hypertension patients in one of these groups is critical because their management, treatment, as well as their response is different. However, currently the main or the gold standard for such classification remains the invasive right heart catheterization, particularly the pulmonary artery wedge pressure being above or below 15 mm mercury. Because this is obviously an invasive method with associated risks and discomfort, it is still of critical need to find non-invasive modalities to classify these patients non-invasively. Therefore, the purpose of this study was to assess whether for the flow MRI hemodynamics of the pulmonary artery, particularly kinetic energy and viscous energy loss, can enable us to non-invasively classify pulmonary hypertension patients to pre-capillary versus post-capillary. And the methods of this study starts by the input is the pre-processed for the flow MRI data. We segment the entire right heart, and from here we segment three compartments or segments of the pulmonary artery, and these are the main pulmonary artery, left pulmonary artery, and right pulmonary artery, and we segment them separately. And after that, we compute per segment, we compute voxel-wise kinetic energy mapping, and then we compute the total kinetic energy at each of these segments over the cardiac cycle, and from that we calculate the peak kinetic energy over systole per segment. And then we computed also the viscous energy loss rate, again voxel wise over each of these voxels, and then we compute per segment the total amount of viscous energy loss rate over the cardiac cycle, and then we compute the peak systolic volumetric viscous energy loss, and these are computed according to our recently published work that's cited here. And these measurements are normalized by the segmented volume to account for different sizes. Our cohort included 51 pulmonary hypertension patients that were prospectively included, and these accounted for 24 pre-capillary and 27 post-capillary that were pretty much matched for age and gender. And they were classified based on the gold standard right heart catheterization that was performed within 28 days of the flow MRI. And we use whole heart for the flow acquisition parameters as a standard as listed in here. The results of the pulmonary artery kinetic energy show that post-capillary patients had almost 2 times higher kinetic energy in the main pulmonary artery compared to the pre-capillary patients, and the RPA also it was about 60% higher in the post-capillary patients compared to the pre-capillary. However, in the left pulmonary artery, interestingly, the kinetic energy was not significantly different between the two groups. Now, the results of the viscous energy loss was consistent with the kinetic energy, showing that the energy loss in the main pulmonary artery was also significantly higher in the post-capillary versus the pre-capillary patients in both MPA and RPA, and that was about 50 to 60% higher in the post-capillary versus the pre-capillary. Talk about the median here. And again, the LPA was energy loss was non-significantly different between the two groups. Our results are encouraging, but there are a few points to be discussed as well as limitations to be addressed. The first most interesting finding was that we found that it was the MPA and RPA energetics, but not of the LPA that were significantly different between the two groups, despite that it's the LPA that's actually wedged by cath to differentiate between the pre versus post-capillary. And there are potentially a couple of explanations for this. The first one, it could be related to the fact that we use pre-capillary group, which can be mixed from the different WHO groups, particularly group 1, 3, and 4, where particularly groups 3 and 4, they are lung initiated, or they are based on underlying lung disease, and it could explain the RPA energetic differences. But that in itself can be very interesting if holds, because it would mean that you are actually able to be sensitive to changes or alterations coming from the lung disease. However, we cannot really conclude these findings fully from such an observational study. The second potential reason behind this could be related to the fact that some of these pre-capillary patients might not be purely pre-capillary, because there is a coupling between the left and right heart dysfunction, and some of these patients may actually exhibit some form of or some degree of left heart disease. And that will be our future work, to look into the cardiac function between in these patients, as well as looking into the association to the cath pressure measurements, as well as looking into the different WHO groups. In conclusion, for the flow MRI, volumetric measurements of kinetic energy and energy loss were significantly lower in the pre-capillary patients compared to the post-capillary patients in both the main pulmonary artery and the right pulmonary artery. These results may therefore support for the flow MRI as a potential non-invasive modality in differentiating or classifying pre- and post-capillary pulmonary hypertension patients non-invasively. However, future studies are still needed with larger cohorts, as well as studying different WHO PH groups, as well as the association with cardiac function. With this, I'd like to thank you all for your attention, and I'm happy to receive your questions in the QA or via email.